Well, everybody, we are so excited to have Rene Cabral-Daniels with us today. She's the CEO of Cenevia, and it's going to be an amazing conversation. Renee brings years of experience within the area of healthcare and looking at the role of technology. She's actually formerly a board member of FHIMSS North America and has spent a multitude of years focused on bringing the federally qualified health centers of the state of Georgia together. And in that work, there's lots, as you all know, that is really key to delivering care directly to communities. And Virginia itself being a very diverse state, I'm just elated to have her with us today. Renee, welcome.
Well, thank you. I'm happy to be here, and I've read so many great things about Match and the coalition and all that's that you've done and are planning to do, and so kudos.
Thank you so much. Well, let's just get started. Why don't you begin by telling us a little bit more about yourself and about the organization?
Sure. Well, as you noted, I've been in healthcare for a bit. Actually, I can't think of a job that I've ever had that wasn't involved in healthcare. My first job in healthcare was as a tray girl at Nantucket Cottage Hospital, and that was when I was 14. I've served as an attorney in the Office of General Counsel for CMS, worked for the health department for about a decade here in Virginia. Did lobbying on behalf of patients, and now the CEO of Cenevia. Let me just tell you a little bit about Cenevia. It's been in existence for over 25 years, and we're excited about that. It started as a way to have the network strength of federally qualified health centers in Virginia to be able to truly partner with different entities such as managed care plans, et cetera. So they started Cenevia, and Cenevia is a C corporation, so we're for-profit, but our board members and our shareholders are all nonprofits. So it's a really neat smattering of different organizational structures, and so we get the best of both worlds by having that. So in terms of how we started, I noted we started off more in the managed care space, but we're up to 26 different federally qualified health centers in the Commonwealth of Virginia, and we have over 150 sites. And the services that we provide have expanded from just managed care negotiation to credentialing. We're NCQA certified. We're really happy about that. With information technology services, revenue cycle management, and as well as a host of other services. If there's anything that our shareholders need assistance with, we reach out to them. But I think more than just saying we're doing a great job, I think our audits probably say it best. As I said, we've been NCQA certified for over 10 years. We recently had a SOC audit, which is a system and organizational controls audit, which is really big, especially in the IT space. You want to make sure that any entity that's working in the area of IT can go through a SOC audit successfully, because then their systems are set up well. So I'd be remiss if I didn't say that we make it all possible because we have an outstanding staff, and they're the ones that make such achievements possible.
That's fantastic. And I know it probably is not easy, right? I'm sure there's a lot that goes into educating centers about the need for maintaining those that compliance. Is that fair to say?
Oh, that's definitely fair to say. Given my legal background, I'm a little bit heavy, shall we say, in the compliance area, but I think it has really helped us, and I think the audits are a testament to that.
You know, earlier you and I had been talking about how important digital technology is to maternal health. And some of the centers, if I am correct, are actually providing maternal health services. Can you talk a
Exactly.
little bit about that? What is the role of the FQHCs in providing maternal health, and how
Mhm.
does technology tie into some of that?
Okay, great question, because I think it shows your question speaks to the strength of FQHCs, and that is that there's not a one size fits all. The purpose of an FQHC is to serve the community that it's in and its service area. So if in fact maternal and child health care is needed within a particular community, then the FQHC will offer it. And I'd like to just share with you one of our centers in Northern Virginia there's a tremendous need in their service area for maternal and child health. And what's neat about all of our centers is that while a lot of hospitals and other entities were getting involved in different areas with regard to information technology, our centers were at the helm of that. And so a number of them have been on an EHR for almost 20 years now, which is pretty remarkable when you think about it, because it means it's already integrated into the delivery of services. So in the need for the community in Northern Virginia, there's a wonderful doctor. Her name is Dr. Martha Wellman, and she's also we have a medical management committee within Cenevia of the leaders in medical management. She also leads that, but it's her center, Neighborhood Health, is known for ensuring equitable access. So the challenges that they have there is not only that they need maternal and child health, but their language barrier, the limited English proficient population is another challenge. And so Dr. Wellman speaks both English and Spanish, and that's really helpful. Her program has been recognized nationally for its excellence in maternal and child health. The Bureau had a challenge for innovative ideas to bring pediatric patients who fell behind on their care due to COVID-19. And so they had the promoting pediatric primary care, primary prevention, I think it's P4, challenge to increase pediatric vaccination rates and well child visits. And that's one of a very popular quality measure for a lot of our managed care entities. So Neighborhood's health proposal was to increase the vaccination rates by using a text messaging campaign, which they used through their EHR. So it wasn't a matter of having to hire staff members to do whatever. They were able to do a campaign through the EHR to send it out to identified individuals, and they were awarded a $10,000 award to pilot this program. And so we also have in our rural areas of the state, as I say, it's not just the urban areas, but we've got to serve the community. But Johnson Health Center offers a full range of obstetric and gynecological services, including delivery. Not all FQHCs offer such a wide range of services. Well, that's just to hit
Really
up on the
fascinating.
highlights.
Yeah, that's amazing. And I mean, you're exactly right. They don't all offer that sort of broad, sweeping range of services. That's pretty impressive. And I guess one of the reasons why it makes me sort of, really pause is because we know about maternity deserts, right? We are seeing hospitals left and right being closed. I'm sure that's, it's definitely happening in the state of Virginia as well. How
Right.
do you, as a result of that, I presume then some of the qualified health centers are picking up the pieces of what's left behind from that. Is that sort of changing the array of services as well that are being provided?
Great question. And what we find is that as services from tertiary care entities tend to ebb and flow. FQHCs are always there to serve their communities and the people who may not have services as a result of those changes. We're seeing a number of hospitals in our area trying to focus less on inpatient care and focus more on, if they have, for example, a managed care product, focus more on that. And so in doing so, that means some of the care that the people in the community may need may not be available. So yes, the FQHCs are accustomed to being able to do that, and being able to do that very quickly, because they, unlike other health entities, FQHCs have to see the medically underserved, they have to serve the Medicaid population, and they have to serve the uninsured. Other entities can pick and choose people within the community that they'd like to serve. And of course, too often, Medicaid and the uninsured aren't at the top of the list. So they're really getting the insured as well as uninsured, and people who have the most severe medical challenges.
Wow, that's fascinating. And it's nice to know that there's sort of that rock within the community, right? You need that. I mean, healthcare is not one of those things that sort of it's on or off. It's always on. Someone's always needing it.
Right.
So sharing that, let's talk about it in the context of maternal care and maternal mortality and morbidity. Love for you to talk with us a little bit about the state of affairs in the state of Virginia, and maybe even look at how that's been changing over the years.
Right. Okay. So first of all, as I said earlier, I used to work for the health department, and I've seen so many great things happen, and I have seen the outcome of great leadership in an area. So we've had a few commissioners who've made it their personal charge to make sure that during their tenure as commissioner, because as you may know or may not know, Virginia, unlike other states, you can only have a one-term governor. So
I didn't know that, really.
Yeah, so everything you have to do. So when a governor is elected, they come hitting the ground immediately, because unlike other states where at the end of their tenure, they're just going to work on re-election. In Virginia, that's not possible. So, and that's true for their administration for the most part. They're going to select people, and generally, not all the time, but generally a commissioner will stay for 4 years. So the commissioner, and as we know about healthcare, it sometimes takes generations to really make an impact. And so, so that's a challenge. But we had one commissioner, actually, I did not serve under her, but but I did follow what she was doing. And her name is Dr. Karen Rumley. And under her leadership, Virginia experienced a great decline in both premature births as well as teen pregnancies. So to tackle those both and have success in both areas, under her leadership, over 1,000 babies more babies were carried to term over the 39-week gestation, which is really remarkable, because let's face it, it's only 40 weeks generally anyway. And the teen pregnancy rate fell by 22%. So that's really remarkable. I know I had been at the health department before Dr. Rumley came, and I know that people worked assiduously on those areas. And then recently, when we had Governor Ralph Northam, well, unlike other states, Virginia's commissioner has to be a provider. You can't be an MBA and run the Department of Health in Virginia. I know that's not true in other states, but he's actually a neurologist. So we had a neurologist running the Department of Health. And in 2019, the maternal mortality rate for Black people, Black women actually who were pregnant was 3 times the rate for white and Latinos. And so he got together a commission that would prioritize fixing this. And so what was really neat is we had these successes with Dr. Rumley, and then Dr. Northam comes and he says, okay, it's great that we've had those successes, but let's look at it in terms of race. You know, we've had these successes overall, but we're looking, if we look at the numbers by race, we're not finding that the successes have been as great. And so he has this committee to focus on racial disparities, and they came up with a maternal health strategic plan. And what I thought was really neat about the plan, it wasn't saying, here's what the health department is going to do, because no entity is going to make a difference in that way. But rather, he came together with a public-private partnership and got everyone together to make that improve. And so I can, if you want, just share with you some of the health ranking lists that come from United Health Plans list in terms of how is Virginia doing? You know, we have this commission, but how is Virginia doing in 2021?
We'd love to hear that. Yeah.
Okay, so teen births decreased 32% for per thousand females aged 15 to 19 between 2013 and 2019. Uninsured people decreased from, and of course we know that access to insurance has a lot to do with access to quality care, from 15% to 10%. Obesity, unfortunately, increased from 24 to 30. And what we need to do there is to say, we can't look at maternal and child health in a vacuum. You know, if we're seeing that women in general are becoming more obese, well, when they're between the ages of 15 and 44, childbearing ages, if obesity is a problem in general, it's likely to be a problem during gestation.
Absolutely. Point well taken.
I'm sorry.
I said absolutely. Point well taken, for sure.
And also, if we look at mental health, you know, people think, oh, well, maternal and child health, what does that do? What does that have to do with behavioral health issues? Everything, because if you're not doing well emotionally, you're not likely to be doing well physically. And if we don't address those issues, and we're seeing that actually it has increased. And so that's another area that while we're focusing on maternal and child health issues, we've got to go further upstream to see, well, what are the challenges that are being faced by the population, and how do we change that? How do we address those? I think another change that I've seen that I think is really great is that, excuse me, I'm just going to take some water. The Virginia Mortality Review Team focus, historically, it always came out of Virginia's Office of Family Health, which makes a lot of sense. And I think this change was very telling in some ways, in a very sad way, that the Office of the Chief Medical Examiner became a co-leader in that effort, because if you're going to focus on mortality for maternal health, why not involve the entity that's focused on what is it that people in Virginia are dying from, and how do we change that? What is it that we can do during their lives to prolong lives and to eliminate morbidity and certainly mortality? So anyway, so that was very telling, and I think it will certainly make a difference. But we know that CDC data show that Black women in America are 3 times more likely to endure death related to pregnancy and childbirth in white women, regardless of their education or financial means. I'm going to tell you a little story about that. I gave a presentation probably 15 years ago where we were talking about the issue of race and mortality. And I was given a talk, I don't even remember where I was, and someone raised their hand in the audience and said, well, there's nothing new about that, because if we look at a number of economic indicators, we know that if you look at it from an economic gradient, that certainly people who are overrepresented in the economic gradient are likewise going to have the same outcome for mortality on a number of areas. And it was clear to me that people really don't hear the last part of that sentence, regardless of their education or financial means. And I think that she asked a question that other people were thinking, oh, that's not surprising, until you consider that, you know, I'm, as an African-American woman with a, you know, law degree, master's, educated in Ivy League institutions, still my chances of having a negative outcome from having a child is high only because of my race. And that's where the problem is. Not because I'm not doing the right things, not because I don't know what to do, not because I don't have the economic resources to do what's needed. I'm doing them, and yet that's still not good enough. So anyway, another report noted that 44% of pregnancy-related deaths were due to a provider-related factor. It's not enough to just educate the women who are going to be pregnant. We've got to partner with providers and make a difference here.
Well, you've pointed to some really poignant factors, right? Poignant points that do get quite overlooked. I think it's actually in the instance of the experience that you had where someone was sharing what they are drawing some conclusion or inference by misinterpretation of the data. I think I'm glad that she actually made that mistake aloud, because it gives the opportunity for us to go back and course correct. And, you know, what's also, of course, sad are the challenges that we're seeing, like this rise in obesity that you had pointed out. You know, we do know that there is a significant percentage of cases for which obesity is a contributing factor. Of course, that's not the majority of the cases, but it is a factor. And there are other things, other elements that can be a factor as well, like sexually transmitted diseases. And you know, I've been watching some of the news and talking amongst our co-chairs, and we had noted that there have been some changes or rise in the increase of sexually transmitted diseases in the state of Virginia. Do you mind talking a little bit about that and how that may be impacting and what is the state doing about it?
Great question. We know that from the 10-year period ending in 2017, Virginia had a 158% increase in just syphilis cases alone. And here is a disease that we thought we had eradicated. Clearly, we haven't. Some of our statistics within the Commonwealth of Virginia with regard to sexually transmitted diseases rival and outpace the numbers that you would see in much less developed countries that don't have the resources that this country has. And so that's another challenge. When we talk about early stage syphilis, we know that in 2020, there were 1,288 new cases of syphilis, which is an increase of 228 cases and just looking at it from the prior just 4 years earlier. So what we're finding is that we're going in the wrong direction when it comes to sexually transmitted diseases. I do think sometimes we're victims of our own success, right? We've had incredible positive results with HIV positive patients and targeting different areas. And so people start thinking, okay, it's no longer a problem. And they let their guard down and they're not as focused on engaging in safe sex practices. So with that, it's not just a challenge to the person who's being affected, but we're looking at the next generation. You know, if in fact children are being affected, which they often are, with these sexually transmitted diseases, then all of our successes and all of our our great ability to educate and to have so many different advances are for naught if people aren't changing behavior, because it's behavior at the end of the day that's going to make the difference.
That's so true. And it's also this challenge of funding, right? Funding exists as long as the prevalence exists. And you bring the numbers down, they take away the funding, then the numbers go back up again. And it's just like, it's like a yo-yo diet. I mean, really.
Right.
It's so ridiculous.
And that's another challenge that healthcare, especially public health, faces in general. If you can get a legislator who understands the importance of public health challenges, the challenge that legislator faces is at the end of their term, they want to get reelected. And part of getting reelected is they want to show successes. So if you're elected, for no matter what your term is, unless you have 10-year terms, and I don't know any state that has a 10-year term, often if you make a public health change today, you're not likely to see the result for 10 years. And so what is your competitor going to say? Oh, you passed this bill and we don't see any positive results. And it's been 2 years, you know. So
that's exactly right.
That's a unique challenge, I think, that public health faces.
It's a very unique one. It's a unique challenge for digital technology in some respects as well, right? Because you put these policies into place and you go about this process of implementation. It can sometimes be very painful. And then everybody's like, well, look what you did. You blew everything up, you know?
Exactly.
We were doing just fine. And now, you know.
Right.
Yeah, so it's really very tricky. And on that subject of the digital technology, maybe share with us a little bit about that from the standpoint of maternal health and women's health, how digital technology has played a role, and as you see it, will play an even more instrumental role in the future in managing many of the dynamics that you've sort of shared with us that are going on for Virginia.
Right. Okay. Well, I'd like to say that I think the promise that digital technology offers, we've only scraped the top of the surface. And the reason that I feel strongly about that is because while I was on the board at FHIMSS, I was involved in being a judge for new technology that a number of students had come up with that was just outstanding. I mean, just the apps that they created, the different tools that they had, the ability that they were able to have electronic records engaging in terms of data, and the data, of course, relevant data, not a dearth of data, not an avalanche of data, but targeted data can really make a difference for the providers. And the next generation is going to take what we have done with getting the data from being able to get data from electronic health records, and they're going to run with it. So how do I know that? Because we had, I'm sure you're very familiar with the different interoperability challenges and opportunities. And I think we should, when we think of interoperability, we should think of it as tremendous promise. So, years ago, the promise of FHIR, the fast healthcare interoperability resources. And so we're talking about the promise of FHIR, and I learned about through a number of connections, a wonderful person who really can look in the crystal ball is Anish Chopra. He's just phenomenal.
Yes, he
And
is.
he helped us. And we thought, okay, so if FHIR can take our data into another system and help different providers make a get this information, what is it they can do? And so we used childhood asthma just as an example, and we had an FQHC in the city of Richmond connect with the school system of Richmond, and they were able to see that if a child was seen at the FQHC, the results of what they saw was shared with the school system, so that the school nurse could see, oh, today's Monday, and this child was treated for asthma maybe on Friday, and here's what they did, and here's the results. I think just in having that happen, we can see the same thing happen with maternal and child health. So, for example, rather than for maternal and child health, we know we have a highly migratory population. So what happens is when women are in their childbearing years, or they become pregnant and they move, well, the ability to get the information that's needed so that she continues to get the quality care she needs, it's not available. Well, you get FHIR, you get different apps. And what we were able to do, I'm not sure that you're familiar with it, but there's a group called Code for America.
No, tell us about that.
Okay, so you've probably heard of Teach for America, where you go into low-income areas, and you have, some really great teachers with great ideas and a lot of enthusiasm that young people have, and I once had a lot of that same enthusiasm. But as I get older, sometimes it takes a little bit longer to conjure it up. But what's really neat is Code for America goes into underserved areas, and they're looking for areas to have someone have us one of the students, I guess they're not students any longer, they're Code for America young professionals, come up with apps that will help a community. And so you don't have to wait for your electronic medical record vendor to come up with what you need. You can just get a student from Code for America to come up with the type of app that you will need to integrate all the data. So I think
that is brilliant. Okay, I love that.
I think so too. It's affordable, it's useful, and it has tremendous utility.
Very cool. Thank you for that. Well, we're just about out of time, but I did want to ask one more question of you. I'd be remiss if I didn't, in relation to the reimbursement scene, right? Like policies and regulations, basically that are in motion to help support the adoption of digital health technology. As you mentioned, we're just scratching the surface. I mean, part of that has to do with literacy challenges, accessibility challenges, but unfortunately for many, the reimbursement element, clinicians, we did a study ourselves at Reach where we interviewed obstetricians and gynecologists, hundreds of obstetricians and gynecologists, love the technology, but they themselves need to be trained. And they said, we're not really clear on how we're going to be reimbursed for all this. So what do you see to be the opportunity there? And do you believe we're moving in the right direction? Are we making, I don't know, from my end, I feel like we're not making as much progress as we could be, but I'd be curious to know, what is your perspective and what does it look like in Virginia?
Well, I do think the whole idea that everything has to come from an EHR platform in the future, that's going to be gone. Because with fire, you can get a student, you know, what some people have told me, I just get my kids to do X, Y, or Z, and they can do it. And so I do think the promise of young people having such technological skills will help us, not tomorrow, because they need to be educated with regard to what is needed. But I do think an increase in Title V funds is also what is needed, because right now a state gets, I think, for they have to have a match for every $3, I think, for $4 they have to match that, and it's not something that all states can do. And so I think Title V funding will certainly help. But I do think having financial resources for providers, like I said, the FQHCs have had electronic medical records for a long time, but I know of free clinics and others that don't. And so I think having the resources for all entities to have the data, because it doesn't make sense to have a data repository if not everybody could put the data in there. And I think sometimes it's just the boots on the ground with doulas, for example, having people trained to provide the care that's needed and put information in an EHR. That will be wonderful. So that's about it for me, but I really thank you for inviting me.
Oh my gosh, we thank you as well. I love that you gave that shout out, recognizing multidisciplinary care teams, right?
Right,
Many
exactly.
of whom are right there, they're right on the front line, but they may not in their day-to-day normally have access to those systems to be able to contribute, but yet they have
Right.
so much data that they can contribute.
Right.
So thank you for pointing that out.
Sure.
I can't believe we are out of time, but this has been amazing. Renee, incredible. I hope that we're able to see you again around the Global Health Equity Week that's coming up.
Okay.
Yeah, in November.
Yes.
That will be awesome. There's so many incredible sessions, but this has been phenomenal. And guys, I'm excited about us now moving to an open discussion about some of the many topics that Renee has introduced to us today. So again, Renee, thank you so much for joining us.
Thank you. Thank you. And you'll see me at the next event that you have. I'll be participating. Okay. Thank you.
Thank you.
Okay.